2022 European Thyroid Association guidelines. So the guideline says about how should we diagnose the hyperthyroidism. We should do serum free T4, free T3, TSH with TSH receptor antibody and anti-TPO antibodies in all patients with clinical symptoms and signs of hyperthyroidism. And if clinical pictures are suggestive of Graves' disease, but the thyroid antibodies are absent, then we should repeat the antibody test a week later. But if the antibody test is absent, if the antibodies are absent again, then we should go for thyroid USG and the thyroid scan. It means we have.
So this is an important thing. What they are saying is that they're giving more importance to the
antibodies. Yes.
Are they talking about the stimulatory antibodies or simply trap antibodies?
So trap antibodies.
So if you have features of thyrotoxicosis and trap is positive, it has to be stimulated. So there is not much of a issue. But what they are saying is that they want to avoid a nuclear scan. That is the main message which is coming out of it. So in our setting, if we make it simpler, the trap antibodies will cost around 2,000 rupees or something. So if somebody can afford, that is good. If they cannot afford, then go for eye signs and wonder. If their frank features are there, then it is most likely Graves.
Yes, sir.
Otherwise, you can go for scan. But what they are saying is that now the sensitivity is very good. If TRAB is positive, sensitivity of TRAB is higher than scan or miss. It is higher.
It's higher.
So it won't miss any case. So if TRAB is positive, then it is definitely Graves. If TRAB is negative, then very unlikely. So I don't think scan scintigraphy will help you out.
Yes, sir.
Usually it goes the other way around. If scintigraphy is negative, TRAB may be positive. But anyway, what they are saying is that they want to push the scan later. We also don't recommend scan too much, but if there is a doubt, then you do that.
Now coming to the medical treatment, as we all know, the first line of treatment is the anti-thyroid drugs. And as we have already discussed, the carbimazole or its active metabolite methimazole. And propylthyrosol should not be used because of its hepatic failure risk. And we all know that 0.6 milligram of methimazole is equivalent to 1 milligram of carbimazole. And two approaches have been discussed. One is dose titration and one is block and replace. And the starting dose depends on the weight and the signs and symptoms and biochemical severity. So here the comparison between the dose titration and the block and replace. So the aim in the dose titration is to keep the thyroid profile in the normal range and the TSH below the upper limit of the normal range. But in the block and the replace, we keep both the free T4 and the TSH within the normal range. Here, in the dose titration, we start with the low dose for the mild to moderate. But in the severe, we start with the higher dose of 0.5. But in the block and replace, we start with the higher dose of 0.3 to 0.5. And in the severe cases, we start with 1 to 1.3 milligram per kg. And we also start with the higher dose if T3 levels do not fall in the lower doses.
That is there, but you don't start with 1.3. If they are saying that if it is not coming down, then you can contact go up. That is too high.
Yes,
I would say in that setting, probably we should start thinking of alternate therapies. It is unlikely to start.
And the dose is reduced to 25 to 50% if the patient comes to euthyroid, or 50% if the patient becomes hypothyroid. In the block and the replace, we start the levothyroxine with the low dose according to age and the weight. When the free T4 and the free T3 levels comes normal, and we even start the levothyroxine even if TSH is suppressed and the free T3 or T4 is low or low normal. We titrate the dose guided by the free T4 level every 4 to 6 weekly. We do the monitoring according to free T4 or free T3 in first 4 to 6 months, not with the TSH, and beyond it, we include TSH in the monitoring. If the patient remained hypothyroid at 3 to 4 months, we discuss the compliance. We ask about the use of iodine in the diet or use of any iodine medication, Then we increase the drug by 25%. Monitoring is done every 4 weekly in the first 3 months, then 2 months, then every 3 monthly. The thyroid profile normalizes in the first 6 weeks. And the RCT control has shown there is no difference in the biochemical control between the dose titration and the block replace. But due to the more side effects in the block and the replace, dose titration is most preferred. Now, the beta blockers have been used when there is a sign of moderate to severe thyroid excess. Propranolol and atenolol has been used, and it is contraindicated in the reactive airway diseases when metoprolol is used, and they are stopped when the thyroid hormone levels normalizes. Thyroid storm, it has been already been discussed. The treatment choices, iodine is used, and steroids, beta blockers, and they are mostly always managed in HDU and ICU settings. Now coming to the side effects of we always counsel and inform the patients and the parents regarding the excessive weight gain during the therapy.
So why is the weight gain excessive?
So because as the thyroid level controls the weight loss, thyrotoxic.
They may become more
Obese.
compared to previous one. Why?
There was no definite reason behind this weight gain from.
So this is basically that they were in a catabolic state. And the body is adapted to that catabolic state. We already discussed how all these neurotransmitters and signal pathways are working. So they are conserving energy, trying to conserve energy, conserve weight. All of a sudden, the thyroid changes, the body will take time to adopt, and that's why they are at risk of obesity. So this is a dramatic change which is happening. So you have to be careful that don't. Many times parents also want the child to gain weight, but often you will see most patients, even adults, will say that weight gain has been more compared to the previous one. This is because of this change, reset axis.
Get the baseline WBC including neutrophil count and liver function before starting therapy. Counsel about the side effects and the criteria for stopping drug. The most common is the pruritic rash in the urticaria, which is 10 to 20%, and the treatment is antihistaminics, cholestatic jaundice, in which we stop the antithyroid drug when the transaminases level is greater than 3 times the upper normal. Agranulocytosis, which occurs in the first 3 months, where there is a fever, sore throat, and the ANC level is less than 500, we stop that drug and we consider about the alternate therapy. When the ANC level is between 500 to 1500, we monitor twice weekly. The duration of the therapy is, it should be at least 3 years and 5 years or longer if likelihood of remission is low. Remission rate after 2 years is 20 to 30% increases with longer treatment. Thyroid receptor antibody can be used to predict likelihood of remission or relapse.
This evidence has largely come from adults. In adults, it has been shown that if you are TRAP negative, if you are TRAP positive, you should not stop, because then your recurrence will be 100%. If you are TRAP negative, then 25% will have a relapse. So that's why it has come. In children, it is not very clear. Now, most studies show that by 2 years, only 18% children are TRAP negative. So that's why children have a more chronic, longer disease as compared to adults, because their immunity is more also. That is pretty much the reason.
Factors associated with high remission is older age, female sex, ethnicity, Caucasians ethnicity, small goiter, mild biochemical derangements is diagnosis, low TSH receptor antibody titer, history of other autoimmune disorder, duration of the antithyroid therapy. Follow-up, we monitor thyroid function every 3 to 4 months in the first year, 6 monthly in the second year, and then annually. If
So
there is a
after discontinuation.
Yes, sir, after discontinuation. And if the relapse occurs, then we consider further antithyroid drug. And there is a no role of immunomodulation with the rituximab or K170, which is an anti-TSH receptor antibody. And
this is a novel way of treating Graves' disease.
Yes,
this
sir.
is a TSH receptor monoclonal antibody. So it is going to block the TSH receptor. But it is, so if you have a good antithyroid drug, you can use it. Which condition are we using monoclonal antibodies to treat endocrine disorders? Very effective therapy. Monoclonal antibody to a particular substance which is used to treat
Acromegaly.
endocrine
Acromegaly.
Acromegaly? We use which one?
Prednisone.
Somebody who has got rickets going.
Okay. This was-
FGF23 monoclonal antibodies. There it works different. It takes it out in the kidneys. It basically flushes it out. This is different. This is not blocked there. So the future of blocking treatment will be monoclonal antibodies, but they're very specific. So you are using the antibodies. Earlier you use it for diagnosis. Now you take that and go for treatment.
Blocking.
So this is there, but when you've got a good anti-thyroid drug, what will be the advantage, let's say, of monoclonal antibody? So it will not have adverse effects. So thiamine is going into the thyroid, they are causing so many things. They can cause so much in the blood, in the liver and all. So theoretically it may be safe in that regard. It's only going to work against that. But then it is only experimental.
Now, when we should consider about the definitive treatment when there is severe side effects with the anti-thyroid drugs, when the patient remain thyrotoxicosis even on the high doses, when relapse, but the patient do not want further anti-thyroid drugs, and there is a long-standing poor compliance.